Good morning, everyone. This week, our topic of discussion in general surgery is surgical metabolism and nutrition. So, uh, we all know what is nutrition and how we define metabolism is. Metabolism is basically the chemical processes which are going on inside the body. So, all the chemical processes or reactions, you can say, which are required to sustain life uh, and all the other things which are going on in the body. For example, the development of the body, the hemostasis, uh, the response to the environment. For example, uh, in the cold weather, your body needs to be warm, and in very hot weather, like our body should lose some of the heat which is formed in the body uh, to maintain the hemostasis or to maintain the internal environment. So all these chemical processes, which are uh, important to sustain life, which are enabling us to grow, to develop, to reproduce, collectively it is all called as metabolism. So now again, like a lot of biochemistry is involved. We know what are the different metabolic pathways, what are the different nutrients, how they're absorbed, how they are transformed, how they're broken down, or how they are broken down and they release energy. So of course, all these things, uh, we already understand, we already know the metabolic pathways which are running in our body. So in this lecture, of course, we are discussing the same things, but in surgical patients. Okay, because surgery or surgery is like any kind of surgical procedure is basically a kind of trauma or stress to the body. So of course, like in surgically, and you can say in surgical patients or in critical ill patients, there are the metabolic and nutritional processes are impaired as a result of environmental, pathological, or traumatic factors. So of course, we must know what are they and why it is important, because we must give the proper nutritional support to the patient, to like because like to help them in healing and of course to recover them. So let's start discussing all those things. So as you can see over here, uh, there are different stress responses which occur in our body as a result to trauma or critical illness. uh, there are many. You can see over here that basically it's a hypercatabolic response, and all the organs, they can get affected. You can see over here there is dearrangement of normal metabolic and physiological power processes. There is a lot of inflammation or inflammatory responses which occur due to as a response to surgeries or stress. So of course there is induction of many inflammatory cascades. Then what is acute phase proteins? Now whenever our body have any kind of stress, like even in illnesses or whenever someone have infections, um, many of the proteins in our body, uh, they are either formed more, or either they are, you can say, they are depleted or they are exhausted. So, um, as we all know, that liver is the main hub which is producing the proteins. So, all those proteins simply which change in response to stress or illnesses or in any inflammatory or infectious conditions, uh, we call them acute phase proteins. One of the example of that thing being CRP or C-reactive protein. So in the time of stress, what happens, like in the blood, the level of C-reactive protein or CRP, it get increased. So that's why uh, CRP is one of the kind of or one of the type of acute phase protein. So there is like positive acute phase proteins and there is negative acute phase proteins. Positive acute phase proteins are those which are increased in the body in response to stress, and negative phase proteins are those which are decreased in response to stress. So, anyhow, it's a different topic. So, uh, that's a small introduction of that. Then there is capillary leakage of plasma proteins. There's a lot of fluid compartmental shifts which occur in the body. There is elevated basal energy expenditure. So, our body need more energy during this time. Remember this thing? For example, anyone who has severe trauma or anyone who have burns, all these things lead to a hypercatabolic response by the body. Uh, and this hypermetabolism means what? Of course, like there is more nutritional requirement for these patients, right? So, okay. Now, there is catabolism of muscle protein. There can be oxygen or organ dysfunction and associated morbidity. And the aim should be to assess accurately and accurately meet nutritional demands while avoiding overfeeding, because overfeeding do have its own consequences. Okay, so I'm using the word hypermetabolism, but because the metabolism is in fast in severely ill patients or critically ill patients, right? So not just metabolism is hyper, rather you can say there is the circulation is also hyper, so we call it as hyperdynamic circulation. So all these things, so okay, this one is the simplified overview of metabolic pathways, which you all know. In biochemistry we had done this, lipid acid metabolism, protein metabolism, and glucose metabolism, and we all know what is glycolysis, okay, what is gluconeogenesis, and the oxygen should be present, and uh, how the ATPs are formed. So see, a lot of biochemistry is written simply over here. How the proteins are broken down into amino acids, and the amino acids they can again enter into the TCA cycle, or the amino acids they can combine together to make proteins. For example, here it is written albumin, and same thing with here. We know what is lipolysis. Um, so why I'm showing you this thing, because this is a very simplified, you can say, overview of different metabolic pathways which are occurring in our body, okay, and how they are connected with each other. Now, um, you can see over here metabolic response to starvation and metabolic responses to trauma and sepsis. Okay, Uh, Trauma and sepsis, you can see, okay, first of all, we will go through this one. When anyone is starving, or when you are starving, what happens? The glucose level in the body goes down, and when the glucose level of the body goes down, of course, there is low plasma insulin, there is high plasma glucagon. The liver started doing something called as glycogenolysis. So now what is glycogenolysis? Because we know that the glycogen is stored in the liver, and now it is the time it is going to break down and make glucose, right? Because remember one thing, that the brain, especially the neurons, they consume glucose as a source of energy, right? Okay. Other than that, you can see over here there will be protein catabolism, and uh, there will be hepatic gluconeogenesis. So we all know what is gluconeogenesis, formation of glucose from non-carbohydrate precursors. So simply, in the time of starvation, the body started, or the liver started producing glucose uh, by taking, or by breaking down the proteins or the fats, and that's why, as you can see over here, there is lipolysis, or the breakdown of the fat cells are going on one hand. There is protein catabolism, or you can say the protein is broken down, right? And at the same time, like, both these things are going on, so there is formation of, like, these two are used up to in the formation of glucose. There is adaptive ketogenesis, and there is a reduction in resting energy expenditure, right? Like, you can say, like, the basal metabolic rate of the body, it goes down. Okay, so these are the metabolic responses to starvation. Very simple, right? If you will see over here, these are the metabolic responses to trauma and sepsis. Okay, we know what is trauma, we know what is sepsis, right? And now, uh, see, surgery is a type of trauma as well, and many patients of surgical patients, they may have sepsis. Not like it's not important, but like they may have sepsis. uh, okay. It is very important, you can say, to recognize, like, how much injury is there, or how much trauma is there. So, for example, of course, there is mild grade of injuries, there is severe type of injuries. Okay, so of course, like, in mild grade of surgeries, like, these responses will be mild, but in severe injuries, or severe surgeries, of course, or big surgeries, these response will be greater. Yeah, for example, uh, okay, uh, like, again, this thing can be connected with something called as elective surgery, or emergency surgery, or surgery after a major trauma, anything. For example, like, after surgeries, what happens, like, there are many metabolic changes which occur in the body, there are many immunological changes which occur in the body, and as a result of that, there is rise in temperature of the body, rise in the heart rate, rise in the respiratory rate, rise in the energy expenditure, rise in the white blood cells count. Okay, all the things, of course. Now, all these things need energy, and from where they are coming, of course, like, we know, like, ATP and all these, biochemical things. So now, what I want to show you, you can see over here, whenever there is any trauma or sepsis to the body, what is happening, that there is increased counter regulatory hormones, uh, or you can say the hormones which are called as the hormones of fight and flight. So see, the adrenaline, noradrenaline, they are like, or simply epinephrine or norepinephrine, cortisol, glucagon, and growth hormone, they will be increased, right? So, uh, what happened, okay, this thing is also called as neuroendocrine response. We know what is endocrine system, and we know, like, a pituitary gland is there, which is very very closely related, or you can say placed, and attached, and connected with the hypothalamus. Okay, so what happens, like, the pituitary, in response to trauma and sepsis, it started releasing the cortisol, the glucagon, the adrenalines, right? uh, and chronically, uh, what happens, like, uh, what you can say, in chronic phase, there is hypothalamic suppression, and there is low serum levels of the target organ hormones, or you can say all these hormones. So now the important thing here is to understand is, simply, like, like, all these hormones will be increased, and this is believed, like, these hormones, are beneficial for the short term survival. So that's one of the reason, like, whenever someone have trauma or sepsis, they have increased level of these hormones. Now you can see over here in starvation, there is a reduction in the resting energy expenditure, whereas in trauma and sepsis, what's going on, like, is opposite. There is increase in energy requirements up to 40 kilocalorie per kilogram per day, right? So, see, when there is increased energy requirement, so it means, like, more nutrition is required, simply, right? uh, or on the other hand, um, the metabolic response to starvation, you can see over here, there is reduction in the resting energy expenditure, right? Here there is increase. uh, on the same time, you can see over here, there is increased nitrogen requirements, there is insulin resistance and glucose intolerance. Okay, so, simply, even if the insulin is there, so the action is not so strong. Uh, there is oxidation of lipids, there is increased gluconeogenesis, so more and more glucose is formed, and there is more and more protein catabolism, like more and more protein will be broken down. And you can see over here, there is adaptive ketogenesis, but here there is loss of adaptive ketogenesis, and there is also fluid retention, due to or associated with hypoalbuminemia. What is hypoalbuminemia is simply like the albumin level in the blood will go down, and there could be fluid retention, associated with, or decreased level of albumin in the blood. So these are the metabolic responses which are occurring in the body, and this, like, the first one is also called as a neuroendocrine response. So now, the thing is, um, um, what you can say, uh, all these changes occur, of course, in surgical patients after major trauma, in critical ill patients, and all these things, right? So, now, the important thing is that, all these things, and the release of many cytokines and all the inflammatory or the immune response, which occurs as a result of trauma or sepsis, all these things, they all require more and more nutrition. So, going further, or to discuss further, um, this thing, again, a very good, you can say, figure or a flow chart, which is showing you that, in response to injury, trauma, or fracture, what's happening, there is increased lactate. You can see over here, the liver is responding by glycolysis, breaking down glycogen. There is glycogenolysis, there is gluconeogenesis, there is increased lipid complexes, there is increased urea synthesis, and of course the glucose is going towards to the muscle. In the muscle, there is increased proteolysis. When there is more and more proteolysis, amino acids will be released, which are going to the liver, which are used up for gluconeogenesis. So you can see over here. The urea is going to the kidney. The kidneys, you know, they are the one which throw away a nitrogen waste. So simply, you can see like there is increased catecholamine, increased cortisol, and increased glucagon, which basically increase the lipolysis of the adipose tissue. There is increased fatty acids, which are again going to the liver for the process of gluconeogenesis. So you can see over here, like how all these things are connected. So when there is increased fatty acids, there will be increased ketones, and of course, they like heart is one of the thing which can use that thing. Now you can see over here there is like the inflammatory responses I'm talking about is like increased cytokines, increased electronic acid metabolites, increased hepatic acute phase proteins. I gave you the example of C-reactive proteins. That is okay. Like why I'm giving you the example of CRP or C-reactive protein, because that is the most common test in the hospitals. The doctors order for the patients, and increase oxidizing agents. So cytokines, now you know what are the cytokines, what are the pro-inflammatory cytokines: interleukin 1, a tumor necrosis factor, okay, or interleukins. Like there are many interleukins, and many things are there, right? So of course, like I don't want to go in detail of that, because I'm just giving you an overview. You already know all these things I'm talking about, right? So again, uh, by this picture you can see like what are the changes which are occurring in the body, and why they are important. Why? Because we know that ATP, or adenosine triphosphate, is the source of energy, right? And if there is ATP, of course, uh, all the processes in the body, all the biochemical reactions in the body, all the metabolic processes will keep on running, right? But of course, like once there is no ATP, so of course, like the body cannot do its functions. So, by the way, my definition of life, like what I think or what I believe, what a life is simply it's a flow of energy. So ATP is a source of energy. ATP is the energy flowing, right? So once it is stopped, of course, we call the person dead. Uh, and ATP is the thing which basically releases chemical energy, and it fuels cellular work, and that's why we need a regular and a continuous supply of ATP. And we know that how it is formed. Again, biochemistry is there, right? We know what is glucose, what is amino acids, what is fatty acids, and all these things, right? So I don't think so. Like I have to explain more of these things. Like if you think you are not good in this thing, you can open your biochemistry books, uh, start studying glycolysis, glycogenolysis, or gluconeogenesis, or lipolysis, which is the hydrolysis of triacylglycerols, which are stored in the adipose tissue, right? And they release the fatty acids and glycerol. So now, and we know what is proteolysis, right? So anyhow, going further, this one was, like you can say, a very quick discussion about the metabolism which are occurring in the body. Of course, the story is not that much simple. Uh, we know like the story involves a lot of reactions, and there is a lot of enzymes which are there, and how the energy is produced, how it is utilized by the body. So same thing we should know about proteins, same thing we should know about lipids, and say the same thing we should know about carbohydrates. And we must know what are the essential amino acids, what are the non-essential amino acids, and all those things, right? So this all what you can say thing or story, of course, like we are studying surgical metabolism, so these things are very, very, very important, right? And the story doesn't end over here, by the way, because we know that Not just this, we need a lot of micronutrients as well. For example, we need vitamins, right? And we need many other micronutrients, because we know that these are the things which are basically helping or assisting all these pathways. Okay, so of course, like that, those things are also needed. So okay. uh, Now, like of course, uh, whenever any patient comes to the doctor, okay, uh, like now our discussion will be completely for surgical patients, or you can say from here I will be discussing more about the surgical patients, right? See how you can know what is the nutritional status of any patient or any person. Okay, um, again, going in the same way, not making the things difficult, we can take the clinical history, right? If I want to see like what is your nutritional status, what I will do, I will take the history. Okay, now what are the points you can ask on the history? Of course, you can ask uh, either they are suffering from any chronic disease, either they lose weight recently, how is their appetite, or all these things. uh, okay, so clinical history is very important. See, one of the way to assess the nutritional status of the person is by body weight. Okay, now uh, body weight doesn't means like if someone is obese, of course his nutritional status is good. It doesn't mean like this, but of course anyone whose weight is less than normal, of course he is malnourished, right? So uh, simply we can check either the patient have any malnutrition, either the patient is obese. Okay, things like this. So of course we will take clinical history, we will do examination, body examination. So in the body examination, uh, one of the thing we can check is body weight. And if you will see over here, uh, anthropomorphic measurements, IBW is basically ideal body weight, right? And then there is BMI, which is body mass index. I think like almost everyone, even the layman, or you can say like the non-doctors people, like they know what is BMI these days. That is body mass index. What we do, we take the weight and we check the height, and then we take out the BMI. And based on BMI, we tell like either the patient is in the normal range, or he's underweight, or he's overweight, or he is obese, or the patient comes in morbid obesity, like this, right? Uh, BMI, you can say, is one of the way we can check. And then there is other measurements. Okay, here it is written one which is called as skin fold thickness. Now, what is skin fold thickness? Okay, in the old times, like, or you can say like the pre-industrialization era, uh, like the rich people, they were like quite healthy and fat, whereas the poor people who work in farms, they very rarely they can get fat. Why? Because they work a lot. So when you will see them, what you can say closely, you would know that they don't have much muscle mass even, because they are undernourished or malnourished. Okay, so skin fold thickness, basically how many fats you have, you can check by skin fold thickness, and that can be measured near the tricep. Okay, many other ways are there, but that can be measured by this way. Now these are the other ways to check the nutritional status of any person, like uh, indirect calorimetry, oxygen consumption, determination of respiratory quotient. Then there is body composition analysis. For that, we can use dual energy X-ray absorptiometry. Then there are many biochemical measurements. Okay, all these things, of course, are lab investigations. We can check the albumin level, we can check the transferrin levels, we can measure the nitrogen balance, or we can measure the immunological function. So uh, now you can see over here body weight, as I told you. Uh, okay, why these things are important? Because nutritional status, as discussed in the previous lecture, I told you that uh, like under nutrition, or someone nutrition whose nutrition is not good, they have more surgical complications, right? So they have more mortality, you can say. They may have more mortality, right? So uh, the point here is, in any surgical patient in which we are going for surgery, we must check like either their body weight is in normal, or you can say they are good or not. Why? Because uh, of course, like this, to recover from surgery, uh, their all the body processes will start, the immune cascades and all stuff. Hypermetabolic state will be there. So of course, like, the person or the body should be ready for all these things. So we can take the clinical history, number one. We can take the body weight. As you can see over here, body weight reflects both fluid balance and nutritional status. Okay. Okay. Now, uh, if someone is giving you the history that he lose weight in the last 1 month or 2 months or 3 months, so we must know how much weight is lost. And weight loss percentage can be calculated by usual weight minus the present weight divided by usual weight multiplied by 100, right? This is the one of the formula to check like how much weight loss percentage is there, right? So this thing is very important, right? uh, this formula is very important, and when you will go in the clinical practice, you would know how much weight loss is considered significant. Okay. uh, and we always ask the patient like either they lost the weight intentionally or non-intentionally, things like this, right? So because maybe someone is lose weight, and that is completely irrelevant, that if he lose it by doing exercises, by controlling his diet and stuff like this. But if someone have lose weight and there is no change in his lifestyle, so maybe he's suffering from some condition like uh, um, malignancy, for example. Okay, so this thing. Then I told you about uh, ideal body weight and body mass index. I think uh, we all know what is this, right? So ideal body weight, by the way, you can see over here. Ideal weight, you can see like there is an equation to estimate the ideal body weight. Like for men, it is 106 pounds, which is 48 kgs. For the first 182 centimeters, and 6 pound or 2.7 kg for each inch over 5 feet, right? So this thing, and then uh, you can say over here, for the woman, it is like 100 pound or 45 kg for the first K, and then 152 centimeter. Sorry, for first 152 centimeter, and then 5 pounds, which is 2.3 kgs for each inch, which is 2.54 centimeter over 5 feet, right? So this is one of the uh, thing. Okay, one of the thing, guys, you don't have to remember these things. Okay, no one will ask you about this thing. But of course, like body mass index is important, because this one is very easy. Weight in kg divided by height in meter, and we have to take the square of that, right? This one is square, by the way. This one is also square. I'm sorry. Okay. So body mass index, of course, we know that we use the height, we use the weight, and there is a BMI chart If you haven't seen that, you can download it from internet, or you can see like it is same here. Like the normal weight is basically this one, or you can say this is the normal BMI. Okay. By the way, I should color it in some other color, right? It cannot be seen, so okay. Some other color like blue. Okay. This is a normal, and then there is overweight or obesity grade 1, grade 2, and grade 3. So you can see, and you can calculate your BMI yourself on nowadays on Google. You can calculate your BMI by putting your height and your weight easily. So this is one of the way by which we can check the body mass, like the nutritional status of the patient. And then we can evaluate the calorie requirements. Okay. So now this is very important to check the nutritional status of, for example, a critically ill patient. Why? Because we have to provide them with calories. Okay. The calories they want, not excess calories, of course. So for that we use something called as resting energy expenditure, REE. Okay. uh, and which is also called as basal metabolic rate, or basic basal metabolic energy requirement, you can say. Okay. So this is very important, like, because we have to provide the patients with that calories which they require. Okay. uh, Surgical patients or any critical ill patient. Now you can see over here there are many equations which are used. Again, you don't have to remember that. So one of the equation is Harris Benedict equation, which is written over here. But uh, there are different equations which are basically used, or which are in use in different parts of the world. And why they are used, why they are there, like they are simply uh, use them to calculate or estimate their energy demands, right? So uh, again, you don't have to remember that, but you can see over here, for men it is BMR 6 is equal to, there should be equal here. Okay. BMR is basal metabolic rate is equal to 66.5 plus 13.75 multiplied by weight in kg plus 5.003 multiplied by height in centimeter minus 6.75 multiplied by age in years. Okay, so no one is such a superman that they can remember these equations. And again, you don't have to remember these equations, right? This is just to get, like, to tell you an idea. Okay. And for women, this one is this thing. And what we do, like, by the way, uh, whatever is the answer, they multiply it by a stress factor. Okay. For example, uh, okay. For example, you can say over here, anyone who is on ventilator, we multiply the energy requirement multiply by 1.2. Anyone who have sepsis, multiply by 1.5. Okay. So see, a stress factor of 1.1 and 1.2 has been suggested for minor and major elective surgery, 1.35 and 1.6 for skeletal trauma and head injury. So simply, if you have a patient of minor trauma, whatever is the basal metabolic rate, multiply by 1.1. Of course, it will be a little higher. But if someone has sepsis, multiply that by 1.5. And 1.1, 1.5, and 1.8 for mild, moderate, and severe infections, respectively. Okay. And see, if you will see over here, this may rise to 1.95. So 1.95 is basically very close to 2. Okay. So when we multiply anything by 2, it becomes double. So see, a burn patient may require double the energy which he require normally, right? So see, in the start I was talking about that, burn is a hypermetabolic state. So this is the example of that. That in burn, what is there? Burn patients require double the energy, or double the calories what they require in the normal state, right? So it's such a hyper catabolic state. So this thing can be used. So then there is indirect calorimetry. So again, this is one of the way uh, to check the metabolic status. Okay. Uh, so now, basically, this indirect calorimetry can be done by using some bedside charts. Okay, uh, and how they measure it? They measure it by measuring, you can say, by the gases which they expire or which they exhale. Okay, one of the thing we know, carbon dioxide. See, so volume of carbon dioxide, right? So one of the expired gas we know is carbon dioxide, and we can measure it, right? So what they do, like they put a mask on the patient face, and then they connect it with a mechanical ventilator. Okay, and then see, by the help of this equation, so you can see over here 1.44, 3.9 volume of oxygen in milliliter per minute plus 1.1 volume of carbon dioxide in milliliter per minute again. So see, now this thing is called as indirect calorimetry, okay? Because you are performing some test or you are measuring something, how much carbon dioxide is produced, and based on that you will calculate the resting energy expenditure. So you can see, like, a poor agreement between Meyer and predicted REs has been reported in certain circumstances. For example, in severely burned children, okay, this could be very, very, very misleading. Simply, this thing, like, again, no one is going to ask you about this equation, but you must know, like, indirect calorimetry is one of the thing by which we can check the, or we can know the resting energy requirement for any patient, okay, or the resting energy expenditure. Of course the requirement is expenditure, what they are expending, what they are spending, they require that. So this thing, okay, uh, so one of the example I wrote over here, in burn patients, in severely burned children, this can be very misleading. So also the patients who are on ventilators, uh, or the patients who are in coma or have spinal injuries, it could be misleading. Then there is dual energy X-ray absorptiometry. Again, this is what you can say, one of a technique uh, by which we can monitor the nutritional progress on long term. Okay. So now, what this one do? Uh, like this one is used to measure the body composition changes, the lean body mass, the fat mass, and the bone density. And it's a non-invasive type of investigation, you can say, in which, like, we can take a scan of the patient, and based on that, uh, again, like, uh, we can calculate, okay, we can calculate how much is the lean body mass, how much are the skeletal muscles, how much is the bones, and all these things. So these things can be measured by dual energy absorptiometry. So other than that, of course, uh, like, after that, I told you, like, there are different lab measures which we can do. Okay, so one of the lab measure which we can do is, like, the nitrogen balance. And as I told you, what is uh, nitrogen balance? Okay, see, when we are growing, or a child who is growing, who is gaining height, who's, or simply you are going to a gym, so the proteins you take basically are used in building your muscles. So the protein you basically take are more than the protein which you lose daily. Okay, so basically you have, at that stage, you have a positive nitrogen balance. Or for example, a pregnant woman, the pregnant woman, because inside her there is a uh, baby who's developing, and of course, like, they need proteins and carbohydrates and all these things, to form all this, all the body structures. So the amount of protein they are taking will be more than the amount of protein they are losing, so they have the positive nitrogen balance. On the other hand, for example, the patient who is very sick, or the patient who have cancer, what happens, like, they lose more protein. Okay, So they have some sort of negative nitrogen balance. Uh, so nitrogen balance can be calculated. You can say the monitor to monitor the adequacy of the protein intake. Okay, and I told you in what cases it could be negative, it could be positive. So now there is an equation for the nitrogen balance as well. Simply, uh, no need to remember that, uh, but there is an equation to calculate that as well. Okay, for pediatric assessment for babies, of course, like nutritional assessment in children should be done. Again, we will do the clinical history, physical examination, biochemical markers, and we plot their these findings on the growth percentile chart. If you don't know what is growth chart, you can just again write on Google uh, growth chart of kids or infants. Uh, you would know. uh, it have different lines, and we see like either they are growing normally or either they are declining or whatever, like these things, right? And the last thing which we can do is basically we can check the serum proteins. Now in serum protein, of course, one of the thing is albumin. You can do calcium, you can do many other tests. uh, Albumin is used a lot. Why? All the proteins, of course, they are formed in the liver. Okay, and there is a lot of serum proteins. Many proteins are circulating in the body, right? But albumin is used a lot. Okay, why? Because albumin basically accounts for more than 50% of the total protein in serum, and is a major contributor to colloid osmotic pressure. So anyone like whose albumin level is less than 3 gram per deciliter, it means like their nutritional status is not so good, right? So now um, many things we can use transferrin as well, right? Because many things are there, many factors are there which basically play a role in this thing. For example, some of the proteins have shorter circulatory or circulating duration. Okay, for example, transferrin, they have a half life of 10 days. uh, Pre-albumin have a half life of 3 days, like this. So there are many factors. Okay, and as I told you, like there is acute phase reactant. So wherever there is any stress in the body, uh, many proteins they are formed more, many proteins they are formed less. So especially the proteins which have a longer half life, like albumin or transferrin. Okay, there is down regulation of that. 50 to 70% of the protein with the longer half life, such as albumin and transferrin. Okay, uh, so this thing should be kept in mind. Okay, so but in short, albumin levels are very helpful in detecting the protein energy malnutrition. Okay, so now uh, see, this is all about what we have discussed about the ways by which we can check the nutritional status. Okay, now of course the lecture is getting very long, and we just have like I will tell you now how the things are managed. Now the story is quite simple. Okay, one of the things which I wanted to talk about here is simply um, there is this thing, the must tool. Okay, now again, this tool is not you don't have to remember this thing, but you must know the concept of this thing. See, number one is BMI. Number second is weight loss in 3 to 6 months. Either the weight loss is less than 5%, 5 to 10%, or more than 10%. And then there is acute disease effect. Okay, so see, if someone have BMI less than 20, zero score. This much BMI, one score. This one, sorry, greater than 20, zero score. But someone who have BMI less than 18.5, they will get two score. Someone who lose more than 10% of their body weight, two score. Less than 5%, zero score. and add a score of 2 if there has been or is likely to be no or very little nutritional intake for the greater than 5 days. So, when we take the history, when we do the examination, when we take the BMI, and when we calculate the weight loss in the last 3 to 6 months, we can add these scores. And if the score is 0, there is low risk or low overall risk of undernutrition. Score 1, medium, and score 2 or more is high. So anyone who is getting 2 score or more than that, it means there is high risk of undernutrition. Why this thing is important? If anyone has 0 score, just provide them with routine clinical care, repeat screening in hospital every week, care homes every month, community every year for special groups, for example, those greater than 75 years. Anyone who have 1 score, observe them. These are the things which we can do. But anyone who has score of 2 or more, treat them. In hospital, refer to dietitian. In care homes, refer them to hospital, or in community, refer them to hospital. So they call it that this thing as the must tool. Okay, and this tool is also used to evaluate or to check the risk of undernutrition in these patients. Okay, okay. So this is all about what we have discussed. What is surgical metabolism? What are the changes which occur in the surgical metabolism, right? And what are the things you have to measure, how you can know that someone is malnourished or undernourished, or they need some nutritional support before surgery or in critical ill patient, right? Now let's go on some other slides. You can see over here criteria to initiate perioperative nutritional support. So anyone who have a history of undernutrition or chronic disease, they have involuntary loss of body weight, involuntary, like it's not voluntary, not by exercise or changing diet. Anyone who have expected blood loss of greater of more than half liter during surgery, weight of 20% under ideal body weight, or BMI is less than 18.5. In pediatrics, if the baby have failure to thrive. When you will study pediatrics, you would know what is failure to thrive. Anyone whose serum albumin level is less than 3 or transferrin level is less than 200 milligram per deciliter in the absence of an inflammatory state or hepatic dysfunction. Anticipate that patient will be unable to meet caloric requirements within 7 to 10 days perioperatively. And catabolic disease like significant burns on trauma, sepsis, and pancreatitis. So any of these things require what? Some sort of nutritional support. Again, now this is the chart which shows you what are the contraindications to enteral nutrition. Okay, now what is enteral nutrition? Remember, enteral nutrition means what? That you are taking from the intestines, right? So if you are eating something from the mouth, enteral. Okay, if when we give something by, not by intestines, or you can say by blood, it is called as parenteral. So when we cannot give enteral nutrition, you can see over here, anyone who have intractable vomiting, diarrhea, paralytic ileus, intestinal fistula, GIT obstruction, ischemia, peritonitis, severe shock, severe GIT hemorrhage, severe short bowel syndrome, like their small bowel is less than 100 centimeter, GI or gastrointestinal malabsorption, or you cannot gain access to GI tract, or the need is expected to less than 7 days. So these are the contraindications, like we cannot give them anything by mouth, rather we can use parenteral nutrition. Okay, so now what are the routes of feeding in surgical patients? See, one of the thing I told you is enteral feeding by mouth, okay, or by tubes. So see, one thing is what? Sip feeding. You can give the patient by sips, okay, by mouth. Then there is tube feeding techniques. Okay, in tube feeding techniques, what they do, I think it's better to uh, show you this thing. Okay, see, there is nasogastric tube. You can give the food through that. There is PEG tube. There is jejunal tube. Okay, of course, like this one is by blood, so it is called as parenteral nutrition. So we can give by tube feeding. For that, we can use nasogastric tube. We can use percutaneous endoscopic gastrostomy, and these are the things, what can happen. The tube blockage is common, and all tubes should be flushed with water at least twice daily. Okay, these are the complications of enteral feeding. Tube related, the tube can be malpositioned, displaced, blocked, can leak, or can cause some local complications like erosion of the skin and mucosa. What are the gastrointestinal complications can occur? Diarrhea, bloating, cramps, aspiration, constipation, electrolyte disorders, mineral, vitamins, trace element deficiencies can occur, drug interactions can occur, or infections can occur, right? And what is parenteral nutrition? As I told you, when we are giving anything other than intestinal route. When we are completely giving everything by other than intestinal route, or someone have, for example, contraindications like this, we call this thing as TPN, or total parenteral nutrition. So see, it is defined as the provision of all nutrition requirements by intravenous route. So, for example, someone who has massive resection of small intestine or intestinal fistula. Now, whenever we give parenteral nutrition, there are two ways. One is peripheral, one is central. Okay, peripheral is a peripheral line which is placed. Okay, nowadays there we can also use PICC, which is peripherally inserted central venous catheters, and there are central lines. Okay, I will show you over here. See, if you are maintaining line over here in the hand only, like we put cannulas to the patient, that is a peripheral line. If you are putting a tube C directly from here through the skin inside the central vein, it is central line. And this is an example of peripherally placed central line. So see, they put the what you can say, the catheter or the tube, the cannula from in the peripheral vein, but the tube is so long that it's ending up in the central vein. So it is PICC, peripherally introduced central line. Okay, this one. Sorry, this one, PICC, peripherally inserted central venous catheter. Okay, so this is like all about the routes by which we can do. Now, guys, this is everything is extra, right? Um, you can see over here, uh, whenever we are giving surgical patients like nutrition, so and if we are giving by enteral formula or enteral route, uh, there is a lot of calorie rich preparations are available in the market. So you can see over here, uh, low residue isotonic formulas are available. Okay. Then there is isotonic formulas with fiber. Okay, like of course they reduce the incidence of diarrhea. Then there is immune enhancing formulas. They have glutamine, arginine, omega 3 fatty acids, and things like this. There are calorie dense formulas, okay, which carry like 1.5 to 2 kilocalorie per ml. There is high protein formulas. Then there is elemental formulas. There is renal failure formulas. Like renal failure patients, we cannot give them much potassium, for example. So see, low fluid volume, we cannot give them more fluid even, and concentration of potassium, phosphorus, and magnesium needed to meet daily calorie requirement. There is pulmonary failure formulas, you can see over here, in which the fat content is usually increased to 50% of the total calorie. So what is the goal? The goal is to reduce carbon dioxide production. Okay. There is hepatic failure formulas. Okay. So all these things are available. So these are the complications of parenteral nutrition, like when we are giving something by the blood route, or you can say other than intestines, enteral route. So there could be, okay, remember the sick, there could be hypoglycemia, hypocalcemia, hypophosphatemia, hypomagnesemia. Okay, whenever someone have these things, we call this thing as refeeding syndrome. I will suggest you to read what is refeeding syndrome, right? Then, okay, one thing to make I should make you clear is that uh, in the case of parenteral nutrition, any type of complication can occur. Hyperglycemia, hypercalcemia, hypernatremia, anything can occur. Okay, so this is called as refeeding syndrome. Then there could be chronic deficiency syndromes, essential fatty acids, zinc, mineral. Sometimes we can overfeed the patient. So see, hyperglycemia, hyperosmolar dehydration, hepatic steatosis, hypercapnia. See everything hyper. Hypercholesterolemia, hypertriglyceridemia, hyperchloremic metabolic acidosis, hypercalcemia. So anything can occur. Sepsis can occur at the site of insertion of the catheter, and pneumothorax can occur because see the line can damage, right? So these are the complications of parenteral nutrition. In the end, I will tell you, like I put the slides. I don't remember from the which book, but maybe like usually I use Bayes and Love to prepare the lecture. Sometimes I study a Sebastian book of surgery or Schwartz something. Sometimes Washington Manual of Surgery. Now I really don't remember from where I put the slides, but you can see over here uh, there is enteral feeding, nutritional feeding routes, nasogastric, nasoduodenal, nasojejunal, gastrostomy, genostomy, their stability, their insertion method, there is advantages, there are disadvantages. Then these are complications of enteral feeding. You can see diarrhea, nausea, vomiting, all these things, common causes and management, what management could be done. And then there is complications of parenteral nutrition. Their common causes and their managements are given in this slide. So all the slides are there, right? And in the end, like the last slide is about how we monitor the feeding regime. On daily basis, we take the body weight, fluid balance, full blood count, urine electrolytes, blood glucose, electrolytes, and temperature. Weekly, urine plasma osmolality, calcium, magnesium, zinc, and phosphate, plasma proteins including albumin, liver function tests including protein factors, thiamine, acid-base status, and triglyceride. And after every 2 weeks, we can check the serum B12, folate, iron, lactate, and minor or trace elements like zinc, copper, and manganese. So, thank you so much, guys. That's all for today's lecture. I hope you understand, and I will see you around.